Dr. Muhkerjee, welcome to 8100 Skills Days. Can you tell our staff a little bit about yourself?
Well, my name is Muhkerjee. I grew up in California, and I went to medical school at UCLA. And then after that, my wife and I were both in Nashville, Tennessee for 10 years, doing general surgery and surgical critical care. And we ended up coming back to California to be closer to family. And she's a neonatologist here, so we're glad to be part of the Loma Linda family.
And you also doing some Sicu coverage.
Yeah, I do general surgery, trauma, acute care surgery, and also I attend in the Sicu.
Okay. We're going to talk about trauma patients today. Tell us how the nurse would know that their trauma patient was decompensating.
Well, as an experienced nurse, you kind of get a sense that you walk in the room and something isn't quite right. For me, it's as simple as, or as basic as sitting in the ICU and all of a sudden you see a bunch of people going into a room. When you walk into the room and they look ashen, they look pale, they're tachycardic, they're hypotensive, they're tachypnic, and they will often start to display some changes in their mental status. And unfortunately, that tends to happen right before complete collapse. And so the things to look for in this patient population when they're not doing well, especially if you're not sure what they're not doing well from, the big thing that we want to kind of distinguish this from is sepsis, especially in view of our new kind of guidelines and our new protocols for trying to recognize sepsis early. You want to see, had this patient been doing okay 5 minutes ago, 10 minutes ago, and then all of a sudden, boom, they're now decompensating. That's probably not sepsis. That's probably bleeding. What I see a lot of is bleeding in an uncontained fashion into either the chest or the abdomen. And in those patients who are literally bleeding to death from their abdomen, their pelvis, or their chest, especially for the abdomen, you'll see their abdomen get tight and distended. You'll see for the chest that they develop significant shortness of breath. They'll have decreased breath sounds on that side if they're accumulating a hemothorax. And in many other areas, you may see the blood coming out from the wound in the extremities. It's important to look at the whole patient, to look at signs of bleeding, because you never know. It could be massive gastrointestinal bleeding that you're missing because it's covering the bed sheets and no one's looked at the bed sheets. So when you see this patient and you kind of get that gut instinct that they're not doing well, that's your time before they start crashing to get help. Get your physician team on board, assess the patient head to toe, try to figure out some clues that'll tell you what's going on. Is this sepsis? Is this bleeding? Is this something else? And give as much information as you can to the folks who are helping you. And if you do find a patient that's starting to bleed, you can start to marshal resources like we're going to talk about with the black blood and the massive transfusion and so forth.
What are the physiologic effects of massive hemorrhage?
We talk a lot about the lethal triad. So as you bleed, a bunch of things happen to your body. So you lose perfusion volume, you initially stop making urine and your heart rate goes up. As you lose more and more blood, we talked about the different stages of hemorrhagic shock. Class 1 hemorrhagic shock is pretty subtle. You may just see very minimal symptoms, if any, oliguria, maybe borderline tachycardia. When you get to Class 2 shock, you're talking about people who have lost at least 15% of their blood volume. And those people will almost always be tachycardic. By the time you really get to Class 3 shock, those people have lost more than 30% of their volume. And those patients are tachycardic, hypotensive. They will be tachypnic. And as you get on the stage from stage 3 to stage 4 shock, you start to get those mental status changes. And by the time you get to Class 4 shock, you're very close to complete collapse and possibly even cardiac arrest. The metabolic changes that are going on in your body are you have less perfusion volume, as we talked about. You have less oxygen delivery capacity. So and you also have less perfusion pressure as you lose more blood. So the combination of those two things will result in more anaerobic metabolism, will result in acidosis, accumulation of lactate, and As you lose more and more blood volume, you also lose your body heat, so you become hypothermic. Hypothermia is disastrous for bleeding patients because your clotting factors are all enzymes, and enzymes are by God and nature to work at 37 degrees Celsius. So when your patient is especially down to 33, 34 degrees Celsius or even less than that, those clotting factors do not work well, and patients will continue to bleed. They won't form clot. So we've already talked about hypothermia, coagulopathy, and acidosis, and those are the three elements of the lethal triad. And the problem is, if patients are starting to manifest these things, you're already behind the eight ball, and you have a very short period of time to catch up and possibly make a difference.
Why do we use emergency blood versus just giving more fluids?
We use blood instead of fluids because, very simply, patients don't bleed saline. Patients bleed blood. And they don't bleed packed cells either. They bleed whole blood. And so ideally, if we had it, we would give whole blood. That's what the military does. Obviously, we're in a civilian environment. It's a different setting. So as we'll get into in a little bit, we may call for the emergency blood to get up here shortly. And then we'll call a code black, which indicates that we have a patient with massive hemorrhage. We're expecting to transfuse. And the blood bank will create coolers for us that are prepackaged with the right ratios, which is another thing we'll get into. But to answer your question, why blood and not saline, or crystalloid? Crystalloid has a lot of disadvantages. Number one, it's typically cold. Number two, saline, especially even more than lactated ringers and other things, is pro-inflammatory. Third, it doesn't carry any oxygen, and it is a little bit debatable as to what the true oxygen carrying capacity of our banked blood is, but it's definitely better than what saline gives you. Number four, it has no coagulation factors, so if you're giving blood and blood products, you can give those things, but saline doesn't have any of that, and it rather will dilute all the factors that you have. The last thing I will say is that in actively bleeding patients where they're clearly unstable and they're not doing well, you cannot rely on what the hemoglobin is. You cannot rely on what the hematocrit is, because the blood that's on the floor or the blood that's sitting by the spleen has the same hemoglobin as the blood that's still in the patient's veins. So that number can't be used as a transfusion trigger. In a patient who's actively bleeding, you have to replace the blood and look at the hemodynamic parameters and say, okay, his heart rate was 140, now we've got 3 units of blood in him, his heart rate is coming down to 130, 125. That's how you know that you're getting the endpoint, and it's not waiting for the blood gas to come back with hemoglobin.
So what would your endpoints be when you're massively transfusing blood?
When I call a code black, and I'm trying to think several steps ahead, by definition, in an actively bleeding patient, you're not necessarily looking for a hemodynamic endpoint. You're looking to stabilize the patient until they can get to a place where you can stop the bleeding, whether that's the operating room or interventional radiology are the typical places, or in the in other settings like you have massive bleeding from the extremity, you can get a tourniquet, you can get other things. So the second that you start thinking about massively transfusing a patient, you should be thinking about how do we stop the bleeding. But that being said, the endpoints that you're looking for are hemodynamic. I do check a lot of blood gases to look at what the lactate is, to look at what the pH is. The other thing that's very useful with the blood gas is that very frequently patients will become hypocalcemic because red blood cells have chelating agents that will bind calcium, and that's part of the preservative effects that are necessary to keep them viable. And so a good rule of thumb is if you're giving a whole cooler of blood, you should probably be giving a couple of grams of calcium, or at least one, or at least checking it. So I think frequent blood gas monitoring is helpful while you're marshaling the resources necessary to control the hemorrhage.
What ratio do you transfuse blood products in massive transfusions?
So that's a great question. And it's been a question that's been extensively studied. It's been extensively studied both in the civilian population and in the military. The military was kind of the pioneer in this. in terms of both depleting a lot of coagulation factors and then developing what the ideal ratios were. So the data that we have from studies like the PROPER study are that the closer you can get to 1 to 1 to 1 of red blood cells, plasma, and platelets, the better off that you'll be. So why the ratio? It's the most physiologic. When you're giving the red blood cells, they, by definition, don't have any coagulation factors. And even the plasma that you're giving, if it's been stored as frozen, does not have complete coagulation factors either. So you have to kind of give everything together to ensure that you're getting enough of the coagulation factors and enough of the platelets, keeping in mind that all of our banked blood is not as effective as it is when it comes straight out of the patient's vein. What you'll frequently see in the real world is that plasma takes some amount of time to thaw, and platelets take some time to get here. So realistically, you're probably going to be giving some crystalloid to just keep the patient alive and getting blood, but then you have to keep track of what you're giving. So if you're 4 or 5 units of packed cells in, you have to start thinking about, how do I get the platelets in? How do I get the FFP in? Which brings up the idea of the massive transfusion devices that we have. So the important thing to realize is that, especially if you have something like a level 1 transfuser, you can't apply pressure and squeeze in a bag of platelets. You can do that for plasma, you can do it for blood, but not for platelets. So the best thing to do with platelets is, while you're hanging all the other stuff, have a different peripheral IV and just use it for platelets and let that go in. And then by the time you've slammed everything in with the level 1 transfuser, your platelets are in, and then you can go to the next one. Unfortunately, what happened in one of my cases, in which the patient died, I don't know if this patient could have been saved or not, probably not. But at the end of the case, we had given 6 coolers of blood at my previous institution, and I walked out of the room after the patient had died, and I saw 5 bags of platelets on the anesthesia table. And that's what you don't want to get, is a deficiency of one set of transfusion, because they're all necessary. If you don't have platelets, where are you going to get the clot from? You can have all the clotting factors in the world, but you need the platelets to bridge all those clotting factors together. So these transfusion ratios are critical. And in real life, you're not going to be giving them 1 unit after 1 unit after 1 unit. But you want to have a scribe who's keeping track of your resuscitation and saying, okay, well, we've given 3 units of blood. We should think about giving some plasma, giving some platelets. And that way you can kind of keep what's going into the patient as physiologic as possible.
What is TXA and when is it indicated?
So tranexamic acid, or TXA, is a class of agents that is related to other medicines you may have heard of, like Amicar or aminocaproic acid and apropinin. And these are drugs that are called antifibrinolytics. So what you'll see on one of the handouts is that there's the clotting cascade. And at the very, very end of the clotting cascade, you have fibrinogen going to fibrin. And the fibrin forms a plug that is the basis of the clot, along with platelets. What will sometimes happen in some sets of patients who are either critically ill or hemorrhaging or having other issues is that you get this process of fibrinolysis. So you form clot, but then that clot is just dissolved right away. And so you may form clot, but it's not really stopping the hemorrhage because it's continuing to be dissolved. So when do we give TXA? So number 1, you have to be bleeding. It's not clear if it causes any harm or it causes an increased amount of clot. No studies, to my knowledge, have really shown that. However, you don't want to give it to someone who is not bleeding. So they're bleeding a significant amount. They may or may not be hypotensive or tachycardic. They may have a lot of external blood loss. You give a 1 gram loading dose, and that loading dose can even be given in the field by paramedics, as occurs sometimes here. And then there's a second dose that occurs as they come in. But the data that we have indicates that if you're going to give TXA, you should give it within 3 hours of the initial injury. Not all the studies have reliably shown that TXA actually saves lives, particularly in the civilian setting, but they have shown that it decreases the rate of hemorrhage and it decreases the number of deaths that are due to hemorrhage. So at least we have a shot at salvaging that patient. The other side benefit is, unlike Novo 7 or FIBA or some of the other clotting factors that we have, TXA is quite inexpensive. So we have to practice cost-effective medicine, and before you reach for the Novo 7, it may be worth thinking about if the TXA is going to help you.
When is the TEG test indicated in a trauma patient?
I'm a big fan of the TEG test. The TEG stands for thromboelastography. And what it is basically a spinning device that uses, I believe the amount of current generated, but it's a spinning device that helps measure the rate of clot formation and the amount of clot formation. And so what you'll see in the handout is you get a plot that looks a little bit like an airline wing. It's curved in one end and then flattens out at another end. And this kind of reflects the stages of clot formation. So there's an initial stage where the factors are all kind of getting together, but no clot has been formed yet. Once enough factors or a critical mass of factors gets together, you can start to form clot, and that clot forms at a particular rate. And then finally, there's how much clot that you form. And after that, there's the question of, is there fibrinolysis? So are you dissolving the clot that you've already formed? The reason why the TEG is so helpful is because it really breaks down the different stages of the clot formation and in some cases the clot dissolving, and it allows you to transfuse exactly what the patient needs. If you contrast that to the studies that we have now, the platelet count, the INR, and fibrinogen levels, except with the possible exception of the INR, none of those things really tell you about what the activity is. You can have a platelet count of 300,000, but that could be insufficient because the patient just got Plavix, Integralin, and 3 other things because they just came from the cath lab. So the TEG helps you determine those things. The downside of the TEG is that it takes time. If you're truly having massive hemorrhage, you can send the TEG, but you can't necessarily wait on the result and then do stuff based on it, because by then the patient will be in the OR. But if you understand that there's a time lag, then you can still use the results to try to direct your transfusion in the setting of massive transfusion. Because of these logistical issues, and because of the fact that as a surgeon, I'm just trying to get the patient to a hemorrhage control environment, whether it's operating room or IR, I don't always send the TEG initially, but after I've stopped the hemorrhage, I like to send a TEG then, because that way I know, okay, the surgical bleeding is all taken care of. Now I need to make sure the patient forms clot and that clot is stable. So how do I help the patient form clot? So I don't know that there's a paper written on this, but I call it clean-up coagulopathy. You try to figure out, well, okay, so now I've stopped the bleeding and I need to help the patient form clot. What do they need to do that? And to help them stabilize the clot that I've created with my surgery or my radiology intervention. So that's where I like to use the TEG, and realistically that may be where we end up using it here the most, because we do need to have some time to have the technician come in and turn on the machine and get it all ready to go. So it's something where you can go to the operating room, call for a TEG, and then by the time you're done stabilizing the hemorrhage, the TEG machine is ready to go. You can send your lab. And hopefully you get up to the ICU and be able to use those results to transfuse the patient and improve their coagulopathy.
All right, thank you, Dr. Muhkerjee.
Thank you.